administering the blood and blood products, and the management of any such complication that may occur. And it was also to ensure procedures for documentation of transfusion in the nursing and medical and laboratory records were also done, provided and included procedure for reporting on any adverse events occurring in relation to transfusions. So the aim was also to develop a checklist for safe transfusion and for early detection of these transfusion reactions if and when they do occur. So this is a table which shows the data that was collected, and this is actual data that was collected at Spanish Town Hospital over a 1-year period, January to November of 2023. It just shows the amount of transfusions that occur on a monthly basis. And we will see in the months April to July, these are the months with the highest level of transfusion. Maybe these are during the holiday period where we have more eventualities that transfusions. So this figure actually shows on a regular basis, and it's almost a routine as it pertains to interventions for patients. Next slide. Next slide. Thank you. So this is now a breakout of showing the transfusion reactions based on that study between January and November of 2023. This shows actually different blood products and the number of transfusion reaction that occurred. So for PAC cells, this was the most frequent transfused product, and we had about 93% of the transfusion records that was sampled that showed that patient had transfusion reaction. The least amount of reactions were those associated with platelets, maybe because platelets are transfused less often. The most frequent type of reaction was compatibility reactions. Next slide, please. Right. So this also shows a breakout of in comparison males to females. This actually showed that more females had transfusion reaction as compared to males. Not sure the reason of this, maybe because the females has a higher circulating number of antibodies, or probably the samples that were done were probably from patients who received transfusion relating to maternity delivery, and at those times the females may have a higher circulating volume of antibodies. Next slide, please. So this actually shows a pie chart which shows the various transfusion reaction in different sectors. We can note that most transfusion reaction, 25% of the transfusion reactions that were seen at Spanish Town were really non-specific reactions. And the next in line, 22% accounted for fever. And we can see the other things: urticaria, pruritus, rash, shortness of breath, hypotension, making up the other percentage. However, of note, while doing this study, I also looked to see globally how does this figure compare with other studies that was done elsewhere. I also found a study, next slide, this study that was done in India, Bangalore in India, and the pie chart representation is almost similar to what was found at Spanish Town, being fever accounting for 27% of those transfusion reactions. And we will see later that febrile reactions are usually the most common because in a Spanish Town, I think fever accounted for 22%. So it's around the same ballpark figure. Next slide, please. No. So our in identifying that we frequently had transfusion reaction, we had to look now at the transfusion records to see what was happening and why, and if there were any adverse outcome to different patients. So we developed this this study to look at the actually through the individual transfusion records at the laboratory to see procedures were followed to see whether or not it occurred. Next slide.
Okay, break up a little.
Next slide.
Right, Grave, not hearing you.
You're not hearing me? I'm sorry. Clearer now?
Yes, I'm hearing you.
All right. So this now when we actually recognize that there was a problem and an actual record or a checklist in place that we could readily refer to in the patient's records. So we thought about coming up with a checklist, but there was some resistance with staff because as staff, they said, okay, there's another document that we have to complete. Why should we complete another document when we already are recording the information in the patient record? So I actually did a random check because what obtained was that when a transfusion is being done, the vitals and checks for the patient are recorded in the actual nurse's notes. So I actually did a random review of these notes to see whether or not there's consistency with persons. So you will see that these are records that a patient sampling was done at different areas in A&E and on the ward. And we can see where at patient number 1, at 6:40 a.m., transfusion vitals were done for this person. There were no other vitals that were taken throughout this transfusion until at the end of the transfusion process. So in between, there was no monitoring at all or no documentation that monitoring was being done. On the ward, you can see the times are done, but not at the specific 15 minutes interval, 30 minutes interval. They're done haphazardly. So this highlighted that despite checks being done, there wasn't a standard practice by all staff. Next slide, please. So this leads us into the development of an actual checklist that will have everybody on the same page. So the analysis of the transfusion audit highlighted this, as I said, went through before, it was a random docket review that was done. And the aim was looking at the current monitoring system used to monitor the patient receiving transfusion. It also looked at where we can promote teamwork with the organization. The process involved, although it involved tedious looking through the nurses' notes because there was not one place that you could go to find this information. And also the entries were randomly throughout the notes. This indicated that the data, whilst the checks were being done, the intervals vary from person to person. So it was not consistent. So next slide, the aim of the Quality Assurance Committee was to develop a systematic approach. So this a representation of the transfusion record. This document was developed as a way of making the patient is deemed for transfusion, this document would be completed. And at the bottom, you see where you have the different times when checks are done. And also, we also included an area to evaluate the IV site to ensure that the IV is always patent to prevent an extravasation injury, as we saw in the case of NG. So this form was developed in a way to streamline and get everyone on the same page to have us standardize the practice of blood transfusion. So the whole process requires transfusion audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review and the use of where we have use of transfused blood components against transfusion guidelines. So once we have a systematic approach, we have a system where everyone follows the guidelines at all times. Next slide. So the transfusion data, in doing an audit, transfusion data may be gathered retrospectively, prospectively, and or concurrently. In the case of the study that was done at Spanish Town, it was retrospectively. Other methods can be the data has to be analyzed. All right, to ensure, and you analyze the data in order looking at safety of the blood supply, and systems must be in place to evaluate, monitor, and manage the risk along the entire blood supply chain, from the donor to the recipient of the blood. And critical components should you have established guidelines and appropriate use of these components. Next slide. Or there were the various challenges that were faced when we tried to implement the new checklist. However, it must be borne out that at the end of the day, the checklist was to reduce the mitigate against the transfusion errors and in the long run, the legal implications of such. Next slide. So we just basically look now on generally about blood transfusion and what this entails. Next slide, please. Right, so blood transfusion being a major life-saving intervention that is done on a daily basis. However, despite it being a life-saving intervention, we need to have continuous monitoring for adverse transfusion reaction, and analysis of these reactions can promote better comprehension of the various contributing risk factors. Blood transfusions are relatively common, and medical personnel provide this service from time to time. But we have to be aware that multiple complications can also be the adverse outcome of these transfusions. Next slide. So this takes us to the 2023 international guidelines from the Association of Advancement of Blood and Biotherapies. This is a US organization that came up with the guidelines for red blood cell transfusion. And of note, in this article, it quoted that over 118 million units of blood are collected worldwide and on each year. And it should be noted that clinicians should offer red blood cell transfusion to patients only when the benefits outweighs the harms of doing so. So we must always remember that we should not just transfuse loosely. So transfusions are associated with risk and adverse reaction. You can have a acute transfusion reaction which occurs 24 hours after the transfusion, or it may be delayed more than 24 hours after you've received a transfusion. Next slide, please. Right. So this taken from the same article that we looked at earlier. These are just highlight the common adverse reaction that one may receive from blood transfusion, and this is data out of the United States. As we see, the febrile reaction is the most common, occurring in 161 cases. In our data from the Spanish Town Hospital, it shows that 22% of the persons that had reaction accounted for 22% of those persons with adverse reaction were from febrile reaction. Also, we have to be aware that the viruses, the various viruses, hepatitis B and C, as well as HIV, are also can also be infections that are associated with transfusion reactions, but they occur in very rare cases. So this take that when we are dealing with administering blood to a patient, we have to look at the ethics and the law of the land that that governs those principles. We have to look at our professional duties. We have to look at the patient factors as well, whether or not the patient is able to consent or there's a third party that has to be involved. So there are many factors and many questions that may come about in terms of when we're administering a transfusion. Next slide, please. Which takes us into ethics. And this, we always have to have this at the back of our mind whenever we are dealing with patients and dealing with any medical intervention. So ethics or morality is the reflective or analytical study of morals, and it is a branch of philosophy critically considers what is right or wrong, or what is good or evil in our matters human conduct. Ethics in the healthcare context is commonly known as bioethics. And we also have to remember the medical, legal, moral decisions, which are perceived to be those that concern the norms or values, good or bad, right or wrong, or what ought to be done in clinical practice. So in terms of blood transfusion practices, there we have to look at also professional negligence. In this dates back to as far back as the 1768 in England with Sir William Blackstone that coined the term malapraxis, from where we now have our present term malpractice, which is this is used to differentiate professionals who do harm, although not willfully, from non-professionals who actually does similar wrongs for purpose of applying certain statutory limitation of tort or liability. So we have to look at our professional negligence and malpractice as we know it. Next slide, please. So blood transfusion. For blood transfusion, we must have some ethical guidelines, and this is the rule and principles that ensure that the right conduct. So we have to ensure that in the practice of transfusion, we have to ensure that certain basic principles are followed to ensure that the patient is informed of the procedure, as well as we receive consent. And this because of the number of medical legal issues that arose as a result of transfusion. In 1980, the International Society for Blood Transfusion actually had their first code of ethics governing the practice of blood transfusion, and this was later adopted by the WHO. So The medical legal implications are very important because blood transfusion is categorized as a medical intervention. Thus, the liability of negligence in blood transfusion is medical. In contrast, the general rule of medical liability of the supervising doctor is based on an obligation of results as a doctor involved in the medical process and will not be obliged to a duty of care as the general liability rule states. So in terms of consent, as it's in ethics, we have to get consent from the patient to administer this medical intervention. And this should be informed consent so that the patient should be aware of the do's or the don'ts or the benefits and adverse outcomes. So they have to be notified that there can be adverse reaction to receiving a blood transfusion. Next slide. So the process we have of informed consent also taking into consideration material risk. What risk is there to the patient who will receive this transfusion? And the law now, these material risks are the ones that are likely to influence the decision of the patient to accept or reject the intervention. So you have to inform the patient about what are these adverse outcomes that may arise as a result of the transfusion in order for them to make an informed decision. Next slide. So ways to give consent. There are many ways that persons can, if they're of their sound mind, they can give their own consent, as well as if there's a proxy or another agent that has been designated as surrogate to give consent on behalf of your patient. So you have to have someone giving the consent, either the patient themselves or a surrogate who is able to make that decision. Next slide. We also must remember that the patient has a right to refusal. So you have to, based on the information that is provided to the patient has the right to refuse the transfusion. And if this is the case, it should be documented that all the different options were given to the patient and the persons have declined, because there are persons who will decline transfusion of blood or blood products, and it may be due to religious reasons, and we have to honor those wishes. But it should be clearly documented so that in the event something happens, you have it clearly documented and the patient should sign to it that they have been offered and have decided to refuse that transfusion. Next slide. So this leads us to a joint United Kingdom blood transfusion and tissue transplantation service that was developed out of these number of transfusion errors and the medical implications that arose. And it stated it stated that it showed that there are errors in identification of the patient, the blood sample, the blood components, and the root cause of many were actually preventable for patients developing adverse events. And about 1 in 13,000 blood component units that were transfused were actually transfused to the wrong patient. So this is something that happens quite frequently at that time in the United Kingdom that now leads us to hemovigilance, which the word hemovigilance comes from a Greek word hema, meaning blood, and vigilance from Latin, which means paying particular attention to. So hemovigilance and surveillance is a surveillance procedures covering the entire transfusion chain, from the donation of the blood, the processing of the blood, to the recipient being transfused with the blood. And this along each pathway, there can be undesired effects that may affect the recipient. Next slide. Next slide, please. So this is just a flow representation of Vigilance pathway. Taking place the donor, you have to make sure that the donor is properly identified, the procedures are done to collect his series of checks and balances to make sure that there's proper labeling, there's proper storage environment, and also the whole area of cross matching to get the or a suitable product for the recipient, and also the right patient is receiving the right blood. Next slide. This other slide just show a more detailed representation of the hemovigilance pathway of blood or blood product that goes through from the collection of the unit of blood to the infusion of the unit of blood or blood product for the recipient. Next slide. So it takes us, I call this slide the balance of blood transfusion, which is a process where there's a lot of medical legal decision making and informed consent, which has become very intertwined with as the patient becomes increasingly knowledgeable about what is their expectation. These expectations also exist with blood transfusion and other chemotherapies that carry risk of adverse outcome and still shadow the memory of the discovery of HIV and hepatitis C transmission. And this was out of persons receiving transfusion that these viruses were discovered. And the existence of both of these tangible risks and a patient perception of the risk it may make, even if it's more appropriate to carry out the process of informing the patient and obtaining consent. Next slide. So this takes us into a few real cases that you can find online. In my search, I came across these Supreme Court judgments out of Jamaica. This one, first one is in 2002, where a child with hemophilia requiring repeated blood transfusion was eventually diagnosed with HIV in 1977. And this was deemed to be as a result of receiving infected blood then, because HIV was very recently discovered in this area. So the tests probably at that time, the checks or the testing procedures were not up to par by then. The other one shows another Supreme Court judgment. This was of a child who was diagnosed with hemophilia at the age of 9 months. And this child actually was diagnosed with hepatitis C and HIV, and this was in 2001. Next slide, please. The other side shows some newspaper articles of this April 2003 article showing where a patient contracted HIV from transfusion that was received. And the other also shown a patient who actually got the wrong blood transfusion and was awarded damages. So we can see the medical legal implication as it relates to transfusion. Out of all of these adverse outcomes, PAHO, along with Jamaica, developed a blood transfusion policy in 2011, and these transfusion guidelines were actually developed in association with the Ministry of Health and was published in 2011, and that is now available to guide us looking at overall blood safety from the having a safe donor, a safe processing of the blood and right down to safe transfusion. So strategies that we can look at to improve the prevention of transfusion errors, because that's why we are here today. So we have to have special means in place to look at transfusion verification. So we have to implement standards and checklists to confirm that the patient's identity, the blood type, and the compatibility. Also, during the administration process of the blood, we have to ensure that staff are trained to recognize the signs of transfusion reaction and respond quickly when there is such. And we return the blood for retesting to see what antibodies may have caused and what's the result of that transfusion reaction. Next slide. Additionally, we have to have post-transfusion surveillance. So we have to implement protocols for tracking and documenting these adverse outcomes, and also encourage the patient and caregiver to report if they are having any delayed symptoms, because we have a system in place where, or a culture where persons will have a reaction and they report later than sooner. You ask, why didn't you report sooner? I was watching it. So we have to develop that culture where a person report early. So we have to, in order promoting a culture of safety, we have to engage the leadership. So the hospital leadership has to prioritize transfusion safety and allocate the necessary resources for training and for technology upgrade. So we know that AI is the technology that is very topical now. So we have to embrace AI and see how AI can help us to mitigate these transfusion errors and look at our systems to see where we need to tighten up. Team collaboration. So we have to create a multidisciplinary approach to these, to how we handle transfusion processes, and we have to always educate the team. Next slide. Best practices. So we have to have some way of standardizing the process. As we looked at earlier, getting a checklist in place where everybody is doing the same thing and the same procedure is established. Technology integration. Use advanced method of tracking, whether barcoding or radio frequency identification methods to enhance the monitoring and reduce human error. So use the technology to our advantage. Continuous improvement. Promote the culture of learning where errors are, looking at see the opportunities for growth and not necessarily to blame. So hence the quality assurance committee, which will look at where errors are made and look at how we can enhance that. So in conclusion, whilst blood transfusion may be a life-saving intervention, it's not without its risks. It is difficult to reduce the legal and ethical obligations of physicians, but to set guidelines, but it is important to maintain safety standards. Although the legal principle of informed consent can be stated in a few words, it does not convey the scope of the responsibility that lies with the physician and the patient for each procedure. Guideline audits and hemovigilance have become an integral part to ensure the safety of blood components and that are used in the treatment of patients. Both civil and criminal liability where negligence is involved is applicable where negligence is involved in the process of blood transfusions. Those are my references, and thank you for listening.
So much, Dr. Baggrave. We could sit here and listen to you all afternoon. Thank you so much for an excellent presentation as usual. And I really am not the person to thank you later on. We hope that you can hang on with with us, and you will be properly thanked for that presentation. That was a lot of information and it was very, very practical. Section, I hope you'll be able to stay back, Dr. Bygrave, so that you can answer. We will do that after the second presentation, which will be done by Dr. Heather Brown Henry. And Dr. Brown Henry is a consultant dermatologist employed to the Ministry of Health and Wellness as the National Coordinator of Dermatology Service and Leprosy Control. She received her undergraduate medical training at the University of the West Indies and postgraduate training from both the University of London Dermatology and the University of the West Indies Public Health. Her responsibilities at the Ministry of Health and Wellness are largely administrative, while also having some clinical responsibilities at the St. Jago Park Health Center, right here in St. Catherine. So please help me welcome Dr. Heather Brown Henry with the diagnostic challenges of a maculopapular rash.
Thank you so very much. You know, I took license with the topic because I was supposed to have spoken about viral versus non-viral rashes. But with the time allotted, I thought if I tweaked it a little bit, I would do better justice to it and give some more meaningful takeaways to the persons who are here today. So I just need my slides to change. I'm here. Okay, great. So and if you notice here too, I have the erythematous maculopapular rash, and I put the erythematous in brackets largely because oftentimes the erythema is actually there, but we just can't discern it in our population. And so I am going to speak first generally about viral and non-viral rashes, and then go into a little more depth on measles and drug exanthem. And these are not necessarily the most common viral and non-viral rashes. Some are common, but some are important differentials of others. And so that's why I've included these. Measles, of course, right now is hugely topical because, of course, of the outbreak that they're having now in the southern United States. I have myself, I don't think anyway, ever seen a case of measles, and I really do hope none of you have either, but wanted to focus a lot on that because, you know, we just have to maintain vigilance, and we at the Ministry of Health and Wellness are really very concerned about the appropriate management and early identification of a case should it come onto our shores. Well, we know about dengue fever, chikungunya, and Zika, those arthropod-borne viruses. All of those have in association with the other clinical features and erythematous maculopapular rash. And then these that the pediatricians tend to see, erythema infectiosum or slap cheek, fifth disease, roseola, and hand, foot, and mouth, those are also associated with rashes. Now, roseola and slap cheek disease tend to be erythematous maculopapular, but the hand, foot, and mouth tends to be more peripheral, you know, localized to the hand, the feet, the mouth, not necessarily all of those three areas. And sometimes too, they also present with a generalized papular rash. And then the other viral one, which I'm just bringing to our attention here, is the seroconversion rash of a primary HIV infection just at the time when the patient has got the acute infection and is going to is developing antibodies. At that point, they have a brief a seroconversion rash. And then some of the non-viral ones, the drug exanthem. And the drug exanthem, that is to say the morbilliform meaning measles-like, the morbilliform rash that you see in a drug exanthem is the commonest presentation of a drug reaction. We know about some of the others, and I'll mention them later on in the presentation when we're talking about drug reactions. But this morbilliform drug exanthem is the commonest presentation of a drug reaction. And then, of course, there is scabies, and we hope with things like scabies that there are other little bits and pieces, clues that will tell us that we're thinking about scabies, but they can have a generalized papular rash as well. And then pityriasis rosea tends to be more perhaps papular squamous rather than macular-papular, but there is a papular version of pityriasis rosea which presents just like any other macular-papular rash. So I want to bring that one to your attention as well. Kawasaki is not one of those really hugely common ones, but one that we must ever have in mind, because not only do they have an erythematous macular-papular rash, but of course they have the potential to have cardiac findings, which are always, of course, a huge concern in that pediatric population. We're seeing a lot less of scarlet fever. I don't know if we're calling it something else. No, it certainly gives you a strep throat. It gives you other findings, which I'll mention briefly later. But it also causes an erythematous macular-papular rash. And then finally, that rash of secondary syphilis, which is a differential of pityriasis rosea, but also presents in the same way. Let's see if I can get my next slide up. I can't emphasize how important it is to take a thorough history. That is going to be crucial to channeling you in the right direction. We want an immunization history. As a matter of fact, you really, in this context, would like to send for the vaccine card to be sure that that patient really has not one, but 2 doses of the MMR if they ought to have had 2. We want a travel history. We want also to know if they were exposed to visiting family and friends from overseas. We want to know about any recent exposure to febrile ill persons. We want to know, of course, and all of this is giving the clinical context. Are we in our rainy period? Have they been exposed to mosquitoes, to insects, to arthropods, to animals? What is their occupational exposure? What about their drug history? And finally, is there a lot of IgE floating around? Do they have food and other allergies? Those are some of the things that we want to ask a patient who presents with a generalized macular-papular rash. You want to also ask about associated symptoms. What about fever? I'll tell you something. Fever is not even going to astoundingly swing you over to a viral or infectious thing, because they can also have a fever in a drug reaction as well. So fever, but yes, you want to know, and is it a big fever? You're going to be doing the examination, a big fever like measles, 103 to 105, roseola, dengue, all of those that give huge fevers. So those are some of the things that you want to know. Itching. Again, itching isn't even terribly pathognomonic, because although the tendency is for the viral ones to be non-itchy and the drug ones to be itchy, you can absolutely get itching in the viral and no itching in the drug. We want to find out about their well-being. Malaise, have they been sort of feeling horrible off their foods, diarrhea and vomiting? Lymphadenopathy, is it localized to the cervical area or is it generalized? Remember, you can get generalized lymphadenopathy in some of the drug reactions as well. What about attendant muscle and joint pains? Headache, is there retroorbital pain? And tell me about the sore throat. the runny nose, the coryza, the oral lesions. We see oral lesions in hand, foot, and mouth. We see oral lesions in Kawasaki's and so on. So all of those are things that we want to ask about. Then we want to zero in on the rash. What can we pick up about the rash? Is it central, that is to say head, trunk, or is it peripheral? And by peripheral, we're talking about primarily palms and soles, like a kind of a more hand, foot, and mouth type of presentation. Is it desquamative? What about the timing of the rash in relation to the onset or recovery of the fever? Where exactly is the rash? How did it begin? How did it spread? What is the site of the rash? This photograph here, perhaps not so great, but shows the so-called Pasteur's lines of scarlet fever, where they tend to have a flexural accentuation in the elbow flexures, in the groin, and so on. So all of these things are all going to sway us in a particular direction, but none of them by themselves are enough to say, well, yeah, this is it. Okay, and so we're going to look at things also like conjunctival injection. We know that the eyes are red and watery in measles, and the same actually also happens too in Kawasaki's. And then of course there's the strawberry tongue of Kawasaki and scarlet fever as well. So all of those. So I'm just bringing to your mind and consciousness the constellation of associated symptoms, things that we want to ask about, all the things that we want to put together in the history pool to gradually build our story and build our case, and certainly build our differential so that we don't miss anything. Let us focus a little bit now then on measles. Now, we know that measles is highly contagious. It may perhaps even be the most contagious infectious disease viral infection. It can be fatal. We know, I last heard about 2 deaths in the current outbreak in the US. It's R0, which is the basic reproduction number. It's somewhere in the region of 12 to 18. And if you look in that diagram there, you will see, if one person gets it, they have the potential to spread it to anywhere from 12 to 18 persons. When you look at things like Ebola and Zika, or even the Delta version of COVID, which all of those were less than 5. I think Delta was about 2.3. So, this is highly contagious stuff. It is a human disease. We do not know of an animal reservoir, and we do not know of an asymptomatic carrier state to date. It is caused by the measles virus, and its primary focus of infection is the respiratory epithelium of the nasopharynx. It is transmitted from person to person via large droplets, and these droplets can remain aerosolized for up to 2 hours. All right, so let us look then at the timeline for disease development. So the incubation period is approximately somewhere between 10 and 12 days, but it can be as short as 7 days, and it can be as long as 21 days. So to be on the safe side, we use the 21 days because we want to be absolutely sure when we are doing management of contacts that we really do capture everybody. We don't have anybody lingering out there who could possibly be on their way to developing the disease, and we ignore them. The prodrome for measles is roughly 2 to 4 days. And then after the prodrome, when the patient actually becomes ill, after the prodrome, the rash develops. So think about it. The period between their exposure and the development of the rash, because the rash is what clinches everything. The exposure to rash is roughly 14 days. It's approximately 2 weeks. They only start to get sick 2 to 4 days before the rash develops. But at that time, we can't tell. that it is measles because they have viral symptoms. It could be anything. They're most infectious 4 days before the rash and 4 days after the onset of the rash. That's the time they are most infectious. So what is the prodrome? I mentioned before that it lasts anywhere from 2 to 4 days. It begins with a stepwise fever. It gradually peaks somewhere between 100 and 105 degrees Fahrenheit. That fever can last up to 7 days. And then there are the famous 3 C's of fever. They have cough, they have runny nose or coryza, and they have a conjunctivitis. And if we had a high index of suspicion, we would see the Koplik spots, which is the only pathognomonic thing that we can see in measles. The Koplik spots typically occurs during the prodrome. It's very short-lived, and you get these punctate, clustered little white spots on the buccal mucosa, which look like grains of salt. I hope you can make that out in this photograph here. And you can find them opposite the lower first and second molars if they have molars, because you know that eruption happens at 6 years. Okay, let me just move this a bit so I can see better. All right, so let us talk about the measles rash itself. It is erythematous, it is maculopapular, and in its early stages, it may be blanching. The lesions are initially discrete, but they gradually become confluent on the upper trunk. It starts at the hairline and progresses from the face to the neck, to the trunk, and then finally to the limbs, the so-called cephalocaudal distribution, and it's also centrifugal as well, going out to the hands and feet. It spares the palms and the soles, and when it is getting better, especially in the really bad areas, it starts to desquamate, and you get this fine brownish scaling. It fades in the same order, so it starts to fade from the head and goes all the way down to the feet and limbs. What else do they have? They look sick. They look sick. Anorexia, malaise, diarrhea, photophobia, and then generalized lymphadenopathy. They really don't look well. How do we diagnose measles? So there are a number of ways that it can be done. However, what we are doing now is the serology for immunoassay. We look for IgM, which is elevated for up to 2 months after an acute infection. If you happen to have taken the sample very early in the rash, in the first 72 hours, it is possible for you to have a negative IgM, in which case we would want to do it again. IgG, we use that to establish whether you have immunity or not. We're interested in IgM in an acute situation for diagnosis. So the case definition, as far as WHO is concerned, for measles is, firstly, a patient has to have a fever of over 101, which is 38.3. So over 101, they must have a maculopapular, which is not vesicular. So maculopapular, non-vesicular rash. And they must, in addition to the fever and the maculopapular rash, they must also have one of either cough, coryza or runny nose, and conjunctivitis. So that is the case definition for measles. Okay, so we believe this patient may have measles. What do we do? If that patient is confirmed or it is highly suspicious that this patient may have measles, we need to admit them for isolation and management. Our healthcare workers who are looking after that patient should be fully immunized and they should wear respirators. We offer the patient symptomatic support with fluids, paracetamol, and anything else that they may need contingent on their situation. We must report immediately to the health department with a class 1 reporting form that I have there displayed. That should go off within 24 hours. and we want the case investigations done, completed, the fever and rash case investigation form within 48 hours. We expect full recovery of the patients within 10 to 14 days. However, fever and rash surveillance must continue on the direct and indirect contacts for 42 days following their last, exposure. And why 42 days? That is twice the incubation period that we use at head office at 21 days as the maximum incubation period. So we double the maximum incubation period. And so that is the length of time that we want surveillance for fever and rash on the direct and indirect contacts. What are some of the complications? Well, first of all, complications will occur in at least 30% of the cases of measles, and more so in persons who are under 5 years and over 20 years. The commonest complication is perhaps otitis media. As far as children are concerned, 60% of the deaths in children occur as a consequence of pneumonia. Patients can have seizures which are independent of the acute encephalitis, although the acute encephalitis is a known complication which occurs up to 6 days after the rash. It is the commonest cause of death in adults. Adults tend to be at greater risk for encephalitis, pancreatitis, and hepatitis. And then SSP, which is a degenerative brain disease, may actually develop up to 7 years after measles. So those are some of the complications to a measles infection. And just a little bit about the measles vaccination. MMR, measles, mumps, and rubella vaccine is given at 12 months with a booster done at 18 months. We need full vaccination with both doses to give 97% protection against infection. We give a booster to ensure immunity in the 2 to 5% who do not respond to the initial dose. And we believe that this vaccination confers lifelong immunity. For a country to have herd immunity, we need 95% coverage. And our figures for 2024 were 94% for the first dose and 93% for the second dose. So you see, we are not quite at herd immunity. All right, I'm going to skip over the vaccine legislation and go straight into drug exanthems. I mentioned before that the morbilliform, the maculopapular presentation is the commonest presentation of a drug-induced reaction. It is a type 4 hypersensitivity reaction in the old Gell-Coombs classification, and it is mediated by cytotoxic T cells. So the target of the attack may either be the drug, a metabolite of the drug, or a protein that is bound to the drug. And so it is delayed. It might take up to 2 weeks after drug initiation, and it actually may develop up to a week or so after the drug has been discontinued. Typically, de-challenge, removing the drug, is required for resolution, but sometimes it mightn't happen right away, as you can imagine, if, for example, it is a metabolite that is being attacked and the metabolite has not yet broken down. So de-challenge may not immediately bring about resolution, and it may actually worsen a little bit after the removal of the drug. Typically, the rash develops very quickly when you give the drug again, much faster than before. So now we have sensitized people on board, and so within 1 to 3 days, you may actually get a rash. In some situations, the rash doesn't come back. That is poorly understood. So what are we required to do as healthcare workers? We must take a really good history. Of course, we want to know a history of any drug allergies. We want to know about all the drugs that have been taken within the past 30 days. We also must reconcile all the prescription and the non-prescription, don't forget that one, medications. We want to look at the timeline of development of the rash after introduction of the new drug. And bear in mind that you can get a drug reaction to a drug that is something that you've been taking for a long time. We agree about typically it will not present in this morbilliform way. You won't get a macular papular type of presentation if it's a drug that you've been on for a long time. Who are the people who are typically at fault? Well, I can tell you, Spanish Town Hospital calls me 9 times out of 10, it's going to be an anticonvulsant. Antibiotics, very common. The non-steroidals, very common. Anticonvulsants we've mentioned. Allopurinol, that tends to be kind of more European, and that seems to be HLA related, which is also the explanation for the anticonvulsants here as well. Antidepressants, antipsychotics, and very certainly the antiretrovirals. And so what are some of the clinical features? Well, again, we speak to erythematous macules and papules. Typically, they're symmetrical and bilateral. Remember now in this context, there generally isn't a prodrome. So then there's no period of feeling unwell and having all of the things. They will have fever, yes, but it will happen all at the same time that the rash develops. It oftentimes starts on the trunk. It may be confluent, they may have involvement of palms, of soles, of their oral cavity. And remember too that fever, itching, and lymphadenopathy can also be a part of the picture. So I know you're saying to yourself, oh my goodness, well, hey, you know, so can we? Very difficult. You put everything together, and after you've put it all together, you come to a conclusion. And I'll come back to that. These are some of the other presentations of drug reactions. DRESS, drug reaction with eosinophilia and systemic signs, acute generalized exanthematous pustulosis, Stevens-Johnson's, toxic epidermal, erythema, all of these that I have listed here, FDs, fixed drug eruption, these are other presentations of drug reactions, but are not as common as the morbilliform, the macular papular presentation. How do we diagnose it? Well, largely based on history, of course, and drug withdrawal. We do a skin biopsy. That's a punch biopsy being demonstrated there, not photographed. Otherwise, lab investigations are very, very little help. And finally, what do we do for these patients? Well, of course, with situation, you may have to remove several drugs till you get to where you want to be, bearing in mind the more common ones, the NSAIDs, the anticonvulsants, and so on. Usually the emollients and topical steroids and oral, remember oral, not topical antihistamines. I'm seeing that happening. No topical antihistamines, please, oral. And usually this triad is enough to address the morbilliform drug reaction, as opposed to one of the more serious ones, which I showed you before. And so with that, I want to say thank you very much, and I hope you had a few takeaways there. Thank you.
Thank you so much, Dr. Brown Henry. That was a lot of information for us to take in. But of course, we ask that you just remain with us a bit because we're going now into the question and answers. I know I saw a question being presented. I think a poll is being done for the question from the first presenter, a question for the first presenter, Dr. Bygrave. There is a poll question that is now up. We're gonna ask that you answer the questions. What aspects of hemovigilance do you believe hospitals should focus on the most to improve blood transfusion safety? And I'll ask Dr. White is going to lead us through that session.
Sure.
I just asked the presenters also to turn on their mics. We've been listening and we've been watching, but we're not seeing the faces. We'd like to put a face to a presentation. And I think we would have had a minute would have gone since this question is up.
All right, so we have about 200 responses. We're going to go ahead and share the responses. And Dr. Bygrave, you just tell us your impression of the responses we have so. In the meantime, so the first question asked, how essential do you think hemovigilance is in ensuring patient safety during blood transfusions? And most persons, 98% respond extremely.
Right, and that's actually what would be important, extremely important. The second question, what aspect of hemovigilance do you believe hospitals should focus on? The most important, most to improve blood transfusion safety. Now we have close call here. 32% of persons responded positively to staff training and transfusion protocol, followed by 28% of early detection and reporting. The 25% cited proper donor screening. However, I would go with protocols because protocols would cover early detection as part of your transfusion protocol. You would have, as well as the proper donor screening and blood testing protocols would be a part of your transfusion protocol. So the correct answer is really staff and the transfusion protocols. So those are the appropriate answers for the poll questions.
I will take a minute or two. Anyone else have any questions they'd like to ask us?
I'll just make a comment. Someone responded in the chat earlier about the Supreme Court judgment for one of the cases in 1977, and they responded that HIV testing was in the 1980s, 85. Well, the case was actually brought about in 1997. 1977 was when the patient was diagnosed with hemophilia. And so it's 1997 that the patient was diagnosed with HIV. And it's correct because it's in the 1980s that HIV was discovered. And I believe it was 1985, the first ELISA test that was developed. And then they start to do wide-scale testing for blood transfusion about 1985.
Dr. Bagay, we have a question from our participant. So they'd like to ask, is there a role for the use of blood substitute in mitigating against transfusion, preventing?
I did not get that. Let me see. The question is in the chat. I did not hear you clearly.
So the question was, is there a role in using blood substitutes in order to help prevent or mitigate against transfusion reactions?
Okay, so in terms of blood substitutes, it's dependent on the requirement of your patient. So in terms of, you have to consider all the factors that are involved, because you have those patients, like patients who, because of religious reasons, may refuse blood transfusion. Say, for instance, Jehovah's Witness patient, they may refuse blood transfusion. Now, if a patient refuses transfusion of blood or blood product, you can use other methods, because you have to, there are other products which can be used. It will not increase your hemoglobin immediately, but it will enhance. Say, for instance, you may choose to give intravenous iron as the raw material to boost the bone marrow in terms of blood cell production. So you may not have a product that will do the same thing that the blood transfusion will do immediately, but you have to discuss with the patient, and it's an individual, a case-by-case basis. It's not one size fits all. So case-by-case basis, you discuss with the patient and see, you come to an agreement as to what best may be suited for that patient, taking into consideration their concerns.
We got one more question. So we saw that you had shared study at Spanish Town Hospital as well as one from across the globe. But were there any regional studies done on transfusion reaction rates in Jamaica, comparing the different regional health authorities?
Well, I have during my checks, there were no studies, regional studies done in Jamaica to show blood transfusion reactions. I did not come across anything. Although there may be studies that are unpublished, but I couldn't find anything actually published.
There's one question in the chat as well asking if we do autologous blood transfusion here.
Autologous blood transfusion is possible, but it's not frequently done. As I said, it would be a case-by-case basis where you have to have the facilities in place to facilitate such a transfusion. Is when persons probably going into big surgery, and they may don't expect something that is done readily.
I'm not seeing any more questions. Time, so 30 seconds if there are no more questions. All right, so we're gonna thank you once again, Dr. We're gonna move on. Question we have a poll going up now. I'll ask everyone to answer as best as they can. Some minutes or two to allow. We'll take 30 seconds for our persons to respond, and then we'll just ask Dr. Heather Brown to talk us through the response to these questions as well as any other questions that you may. Right. Almost 300 responses, and then Dr. Papers. These two. And again, if you have any questions for Dr. Heather Brown, chat. Yeah. We'll wait to hear from Dr. Heather Brown. Looking at the first question, so it's asking about the vaccination rate for measles that's associated with herd immunity, the first disease. And indeed, the vaccination rate is 95%. It showed some 72%. I'm hearing Dr. Brown. Well, my limited knowledge. Let's describe the second question. So this one had a 5-year-old child presenting with a history of fever for 5 days, accompanied by irritability. And the child was also noted to have a history of conjunctivitis, cough, and a runny nose. What is the most likely diagnosis? We had 5 options between Kawasaki disease, measles, scarlet fever, roseola infantum, and a drug reaction. And some 60% of persons had it. This was measles with the classic 3 C's that we had here. Unfortunately, Dr. Heather Brown isn't available to answer the other questions we had. The family can send these questions to her and just have one question. So at this time, we're going to continue with our meeting. And
Thank you so much, Dr. White, and thanks so much, Bagray, for answering. And we await Dr. Brown Henry to respond. If he can, she will respond in the chat as well. And we ask that as we continue, you just post your questions, sorry, in the chat, and we will take care of them along as we go along. So we are keeping on track with our presentation, and we did say we have a number of persons on, and the next presenter is coming from not Jamaica, far away, but I want to inform that we have BVI, St. Lucia, and Dominica. I just want to say welcome to our colleague over there. We started at 207, and at this point, we are at 879. I'm almost seeing 80. Yes, I got it. 880 participants at this time. I just want to say thank you for joining with us. Thank you for deciding to spend your afternoon with us. So our next presenter is going to be dealing with burnout, depression, or both. So Professor Wilma Fletcher Anthony, almost family to some here at Spanish Town. She completed her general psychology at the Capella University, and her dissertation was The Lived Experience of West Indian Youth Reunited with Immigrant Parents in the Host Country, and it's a phenomenological study. She also obtained her Master's of Education in Arizona State University in 1993 as a counselor educator, and a Bachelor of Education at the University of the West Indies in 1988. She's licensed with the Mental Health Council of New York since 2006 and is certified telemental health training in 2021. Also has related professional experience. Sam Sharp College right here in Jamaica as member from 1989 to 1995, after which she became guidance consultant and guidance counselor in 1995 to 1999. Ladies and gentlemen, please help me to welcome Professor Wilma Fletcher Anthony with burnout, depression, or both.
Hi, everyone. Hi, let me know if you can hear me properly. Is that okay?
Yes,
Thank you so
yes,
much.
we can.
Always a pleasure to be with this group. Thank you so much for your warm welcome. I have really enjoyed being present among you. Listening to presentations, I learn so much every time I show up. So thank you. So we are going to talk about burnout and depression. Generally, I'm not talking about fun stuff, so I'm looking to share and yeah. Okay, so we got that. So let me minimize that. Okay, so burnout is used very loosely. It's a term that is used pretty loosely, as is depression. For example, it's very common for my clients to come in and say to me that they are depressed. I currently lead a counseling center at Queensborough Community College in the City University of New York, where I have a team of social workers, mental health counselors, and psychologists. And people will come in and talk about being depressed, but you know, depression is a diagnosis and it has many pieces to it. So we're going to look at that. Burnout is another term that is used loosely, so I'm really grateful for the opportunity to talk about it. As I prepared this presentation, I really dug into the literature and found out a lot more about the way that burnout affects healthcare professionals in particular. So that's the focus of it. So I'll do some general stuff and do healthcare professionals. So burnout, which is not included in the DSM-5, that is my diagnostic manual as a mental health professional, is something we're going to look at the diagnostic indicators of it because it is not there. And so I had to go to the published literature to find out how different people have come to the diagnosis. Depression is easier to talk about because there is a diagnosis. There's something concrete that we have for that. And then we'll talk about recommendations. And recommendations, hopefully some will come from the group and we will to make sure that they are relevant to your population. So burnout is pathological and it involves emotional exhaustion, depersonalization, and reduced personal fulfillment. It is not included in the DSM-5, as I said, and but it has been used since 1969. And a big part of it is powerlessness. And another big part of it is that this is work related. So there are other types of burnout that people talk about, like social media burnout and so on. But for the purposes of this work, we're talking about burnout that happens related to the workplace. So it is feeling of being powerless at work and being having the focus on production and power. There are different levels and definitions for different aspects of people's lives. So there is a deterioration of well-being in the areas of exhaustion, weariness, negative attitude, and attachment or distancing. And I'm thinking, as I go through this, I would invite you to think about where you are in your career, in your work, at this particular time, and consider the extent to which any of these indicators have shown up for you. So are you just emotionally and mentally tired, weary, demotivated, feeling like you can't cope? Do you find that your attitude is negative and you get frustrated easily? And you have negative feelings about yourself. And this may have to do with things like competence. Can I really manage this? Is this working for me? And dehumanization is a major aspect of it. More dangerously, maybe it's detachment towards coworkers and detachment towards clients. That clients and your patients are not seen as whole people who you would provide empathetic services and compassionate services to, but just as work. So that would be that part of it. Then physically, there would be more deterioration of well-being, like sleep disorders. And, you can think about this, what is your sleep looking like? How much sleep are you getting? What is the quality of the sleep that you're getting? I would be willing to guess that it's not much and not great. Then you may find that you're physically exhausted. As you notice, these aspects of symptoms are overlapping. Behaviorally, you may regard clients and co-workers, your patients, as not really worthy of a relationship. And then you may get cynical and become disengaged from the workplace, that you don't feel properly strongly connected to the hospital or whatever the facility is, whatever the workplace is that you're functioning in, that you just feel like you just can't be bothered. Okay, so I'm going to stop sharing for a moment. And I don't know if anybody put anything in the chat. Oh, we're talking about transfusions. Okay, forms. Okay. I'm just checking to see if anybody indicated that they were, interested in that they had identified anything. But maybe that's a scary question too. Okay. Specifically related to healthcare professionals and particularly physicians, these authors in 2020 did this study that found out that burnout among physicians is a very dangerous occupational hazard. And that it has all of the components that we just talked about, the emotional, the mental, and the physical fatigue, the exhaustion, the not wanting to get up and go and be engaged. There's a high prevalence among physicians, and up to 1/3 of physicians are affected by this at some point in their career. I found this number to be really scary. And then there was a recent US study that showed that almost 46% of physicians had presented with at least one symptom of burnout. This is also related to statistics of suicide among physicians, and I'm sure that you're painfully aware of that situation. And it starts from medical school. And if everybody would just reflect on their medical school time, I'm pretty sure you can see how the whole culture that we are immersed in, that we glorify being able to survive on very little sleep. We glorify being able to do a lot, just be overworked and do lots and lots of hours. I don't know if medical students and there how it works, but I know that the medical students here are required to do really long shifts and really intense work. And we wonder whether they are sufficiently prepared for that. So physician wellness is an important factor, and the satisfaction of physicians and other healthcare professionals is a consideration. If you can think back about when you decided to enter the profession that you are in, and the joy and the enthusiasm and the kind of excitement that you brought to it, and whether that is still the case, whether you still feel fulfilled and you still feel happy to be doing the work that you're doing. So there are some contributing factors that we touched on before, like working long hours, the whole bureaucratic administrative work, health recording, being on screen a lot to do notes. I know a doctor here whose shift starts at 8 o'clock and they go in at 5 to ensure that all their notes from the day before are completed, or they stay back for hours to ensure that those notes are completed. For me, as a mental health professional, my hours are I do 50-minute sessions, and in between is when I do case notes. So that is one way that I prevent that from happening. There's a lot of focus on productivity. I know for here among the medical people, the doctors, it's how many patients can you see today? I go to the doctor and my doctor is complaining to me about just the back to back to back to back patients with no break and not being able to have lunch. And if they stop to have lunch, then patients complain, like they have to wait, where's the doctor? And that sort of a thing. So productivity is a big thing. Support from management varies from one area to another. Sometimes people are doing work and not in their area of specialization, that they don't feel relevant, they don't feel fulfilled because they're not doing their best work in an area that they were prepared or trained to do. Sometimes the organizational values may shift, or you may find that you're working in a place just so you can make a living, in a place that doesn't really match your values. And there'd be lack of flexibility and work control. You have your shift at this particular time. This is the work that you have to do, and that you may find that you need some flexibility and you don't have it. All right, so I'm going to ask for some participation. So here are the factors that I just talked about. And in your particular setting, what examples could you generate that would mitigate any of these factors, that would reduce you or anybody in your workplace from having harm from these factors? If you could put that in the chat, and then we would have some little talk around that. What could leadership do? What could you do? What could happen that would prevent these things from occurring? right? People could invest in other areas, like in hobbies, proper handovers, so not so many persons are on call, need for staff, adequate staffing, possible shift system. Everywhere that I have done any kind of a talk about burnout, the situation frequently is with, if we had more people to do the work. A junior staff member in an organization told me a few weeks ago that it takes this many hands to lift a load. And if so many hands are not available, then it becomes really, really hard. Cap the number of hours that can be done before you're required to take time off. So this is a leadership, administrative, organizational factor about leave and taking time off, having teamwork. These are excellent recommendations. Clean functioning break room. Break rooms are very important because this is where people should go to go chill, relax, and genuinely take a break. So they should be warm and welcoming places. Adequate staff, fewer hours, listen to staff, and that is a big morale booster. Who will listen and who will ensure that people's voices are adequately heard. Leadership, better public health education. A big part of public health education, and in fact, education for healthcare providers, is to equip people, with the skills to deal with the situations that come time after an unsuccessful crash. That is a very painful experience. Okay, group meetings to see if everybody is comfortable. So that is a lot of opportunity and ask to really have people being heard. We find that if people are heard, then it is a lot easier. So thank you so much for sharing those ideas. And I know that there are people in leadership on the call. So people are taking notes and understand that their staff need support. So some of the consequences of burnout are depression, and that is where we reconnect to depression, suicide, alcohol and drug abuse, and reduced empathetic behaviors. And you're aware that all of these occur in your professions, sadly. So some of the strategies, in addition to these amazing ones that you just provided, were the personal approaches, which was attention to physical and mental health, activity, exercise, especially outdoors where you can have sunlight and feel, the wind on your skin and that sort of a thing. That is good. Mindfulness training, so you can just learn to be fully present and appreciate where you are, and institution and system-based strategies. This is really super important because no matter what other things get done, they may feel like band-aids if they are not system-based strategies that ensure that people have manageable workloads and that people can take time and take breaks. Among my staff, one of the things that I do with my staff is that I let know that you have sick days in your contract for a reason. It is because they expect you to be sick. And a part of the sick day situation is that as healthcare professionals, that prevention takes up less time than treatment. And so I encourage my staff, if they don't feel well or anything comes up, call in, take the time out and ensure that they do wellness. There was a time when if I was going to the doctor, I would squeeze the little time into my lunch break and go to the doctor. You can imagine how happy the front office staff were to see me, this miserable woman who comes in and needs to be seen immediately because I have to go back to my office because people are waiting for me. So I don't have any time to wait and hurry up already. And I would walk around and pace and make everybody miserable. So these days when I'm going to the doctor, I just take a half day or a day and not send my blood pressure up by doing that. So we need to take care of physical health and take care of mental health. And I don't know the extent to which taking care of mental health is is okay, and the extent to which it may be taboo or encouraged, but that is something that we need to look at. And I'll share a little story with you later about the way my doctor responded to me when I asked him for a referral for a mental health professional. So I like this picture here where it shows the relationships between burnout and the other factors. We have physician dropout, our doctors and nurses not showing up, leaving, not staying the job. People might stay just because they need a job, which is just really the worst thing. I don't know who wants to have a healthcare professional by their side who is just there just to earn a living, and not people who are bringing compassion to the table. So these are some of the factors that have that impact. And this other slide just has the source on it. So I made sure to identify where I got the picture from. For nurses, they found the research showed no significant difference in burnout and depression between doctors and nurses, excepting that nurses are spending a lot more time with patients and may lead to more emotional exhaustion and therefore burnout. And they recommend that nurses get trained how to deal with emotional demands, such as being around patients, breaking bad news, and providing direct emotional support. So that's the difference. Everybody is at risk. So depression, according to the DSM-5, which is my diagnostic manual, is very specific. So if somebody comes in and said they are depressed, they might just feel sad. There might be just one thing, but the diagnosis calls for 5 or more symptoms over a 2-week period, as well as significant distress or impairment, people being unable to function fully, and it is not caused by a medical condition or use of substances. So you can look at the checklist and you can see that there are some overlaps between the diagnosis for depression as well as the symptoms of burnout. Like feelings of worthlessness, feeling like you're not doing a good job, you can't manage, you're not doing your best work, you're not being effective as a professional. This is hard. And so the feelings of sadness are pretty, can be pretty pervasive, but feeling empty and hopeless. If you think that you don't have as much interest in the fun stuff that you usually like to do, if there is change in weight and appetite, sleeping too much or too little, being aggravated, agitated all the time, loss of energy, diminished ability to think, concentrate, and make decisions. And among healthcare professionals, you can see that this is very dangerous. And recurring thoughts of death, suicidal ideation, which can in fact lead to a completed suicide and death by suicide. So I'd invite people to really just remain aware of themselves and, and just check themselves. And in the US, these are the numbers that we have by age for depression. So among women, the highest prevalence seems to be in the 20 to 39, in the 12 to teenagers, among the 12 to 19 age group. But if you are, I think the 10% is really pretty high, and for males, the numbers tend to be less. But then we'd need a lot more time to see how this translates into things like suicidal ideation and completing a suicide. It's pretty common. And this slide just has on the source, like the other one. Okay. So since this starts really early and where we build a whole culture of overwork and no sleep and glorifying people's ability to just keep going like the Energizer Bunny, then the mitigation of risk factors really should start among medical students, where people should be checking on whether people have a history of major depression, if people may already come to the profession with that particular risk factor. And when you layer onto it the demands of the profession, then it makes it that much worse. consider how medical students are having not much sleep, long working hours, and what kind of stressful events are happening outside of residences and internships and school, because people still have full lives. The mentor from my doctoral program taught me something that I speak to people about all the time. And it says simply that life continues to happen while we are trying to achieve our goals. So while people are in nursing school or medical school, things are still happening in their lives. And in addition to that, they have to fulfill the requirements of their programs. So among medical school students, almost 74% reported experiencing symptoms of work-related burnout, and 44% reported symptoms of depression. Those are really scary numbers, even in the general population. But for healthcare providers, this is a very distressing situation. And this research, the other study that I looked at, referred to the doctors who I don't think are called junior doctors in Jamaica anymore, but this study was done elsewhere. And it talks about managing workload demands and patient contact so that you can keep their enthusiasm and protect their mental health. Depression is also treated with medication, so that is the purview of a psychiatrist, treated with psychotherapy, which is my side of the work, and looking at lifestyle. But I saw in the chat that somebody had posted proper diet, exercise, and living a balanced life. So making sure that your relationships are nurtured, that you're eating properly, you're getting enough sleep, and that you're physically active. So just, I recommend that you be brave, that you normalize help seeking and make it okay for people to, admit that they're not feeling good, to admit that they're exhausted, to admit that it's just too much, that they're overwhelmed and stuff like that, and not to look at people kind of weird if they say that. To feel like it's okay to offer support. In my department, we do that all the time. Well, this is our field, but it's okay, to check in with your colleague to say, if you're doing okay, you don't look so good today, and not be scared to do that. To prioritize self-care. So I'm going to tell you about the Healthcare Professionals Day. There's a hospital in my neighborhood that does Doctors Day. And that is where doctors go and they get checkups. A doctor who is a friend of mine told me that it is just appalling how many end-stage diagnoses show up on those days. Mental health professionals, physicians, nurses, healthcare professionals are really bad at doing our own care, of attending to our own care, of taking time. If you think about yourself, when is the last time you took time out to go to the doctor, to get a physical, to get a full checkup, to know what is happening in your life? What is it that you do if you don't feel well? You pop a pill and keep going because you have to, you have work to do. To what extent are you paying attention to your own wellness? This is a really huge thing because, if you bring your unwellness into the hospital, whether it's a physical unwellness or a psychological unwellness, you can see how it is going to impact your patients as well as the people around you. And then I'll share with you the response of my doctor when I asked him for a mental health referral. So about 2 years ago, I developed DVTs and I was in the hospital and I was on Coumadin. And it was explained to me, I don't understand these things, that Coumadin is they're putting the dose up, and this other thing called an INR is supposed to go down until, according to my loved one, who is an anesthesiologist, I am not eligible. I'm not for surgery. So the number is supposed to just be like that. Well, my number was not moving. And, my family in the medical field really tried to keep my spirits up, but I was there for 3 weeks. And it took like 2 weeks for the number to get to the therapeutic level. And it was really very hard. And for me to just lay there and watch my body not respond to medical care. And eventually, I got to the therapeutic level of the INR, and I was so excited because now I could go home and it would be fine. As soon as that happened, I started bleeding. They had to stop everything, start again from scratch. You can see that, that really did a thing on my mind. So I went to my doctor of over 20 years, for like 2 weeks after hospitalization checkup. He gave me the referral to the hematologist. He gave me the referral to the venologist. He made sure that my referral for my needs with my orthopedic surgeon were on point, and he was done. And I said to him, I need a mental health referral. I do not have a therapist, and I need to have one now. And he looked at me in shock. Like I just saw like the blood drained out of him. He was so disappointed in me for asking for that. He knows what my field is. And he opened his mouth and said, you don't need that. You're okay. You can manage. You'll be fine. It's not that bad. Please do not be that doctor. You be brave and bring it up to your patient and say, you have been through a difficult time. Consider talking to somebody about it. You be brave and say to your colleague, and note that you're having a very difficult time. You're talking to anybody about it? Are you seeing someone who can help you talk through this challenge? So my doctor, after a while, went down to the office and he brought me a list of people who would work under my insurance. So do not, just we need to ensure that we are prioritizing mental health and that we understand that everybody needs support sometime. We need to normalize that. We need to make it okay. We need not to go into shock when somebody admits that something is a little off, that they need some additional kind of support. So that is something that we really need to do as we address burnout and the potential for depression. So I think that may be just about where we're at. Yes. Okay. All right. So thank you so much for being attentive and participating. And let me know if you have any questions or concerns or comments.
Thank you so much, Professor Wilmot. Always a pleasure to sit and listen to you.
Thank you. I see some really powerful comments in the chat, like situations related to stigma and the need to have things in the systems, as well as
I see a raised hand.
Okay,
Richard?
awesome. I like that.
Is there a question? Unmute, Richard.
Yes, there's a question. Good afternoon.
Good afternoon.
Good afternoon. That was an excellent and very informative presentation, and really, really very germane in the sense of being relevant not only to our healthcare providers, but there's a point that you made that is very interesting, and that has to do with electronic medical records. Now, in our setting, electronic medical records are seen as the future, and we look at them as a way of improving the quality of care and being more efficient in the services that we deliver. But I note that in your presentation, EMRs are one of the contributors to burnout. So you can understand the dilemma we seem to be in.
Yes, indeed.
So specifically, what is it about EMRs that contribute to the burnout, and what should we be doing better, even as we're in the process of rolling out EMRs in most of our facilities? In fact, currently a number of our facilities are pilots for rolling out EMRs. So I think this is a good opportunity for us to be aware of, where we're going in terms of what you have just pointed out, that, yes, it appears to be the future, but look out for this and look out for that. So specifically, what is it about EMRs that contributes to the burnout? That's my question.
Same thing as that. Screen time is one of the problems. That, exposure to all this screen time, it compromises things like sleep and the whole stimulation response that happens. Another part of it has to do with using time in a timely manner. So this is supposed to help us to keep accurate documents that others can access in an appropriate and easy way. So we want to ensure that you're organizing your time in such a way that you're putting in the information that you need to put in. Some people, I don't know from your side how much information you're required to put in. I know from my side, I have staff who just write a lot of irrelevant things in notes. And so if you can really tighten up the information, ensure that you're putting in all the germane, relevant, and required information without extraneous content, and organize yourself in such a way that it is a systematic kind of a thing. Like that doctor who is going to work or staying back really late, then it is really difficult to, have this on your mind. You come home at the end of the day, you go to sleep with patient information in your head that you're going to put in the following morning. So a part of it is organizing your time in such a way that you can put in information in a timely way, and that minimizes your screen time exposure. I think is that useful for you?
Yes, it is. Yes, it is. And
Okay, thank you.
interestingly, the argument has been made. Of course, we're coming from physically writing in dockets, and the argument has been made that we have younger clinicians who are more au fait with technology and are more likely to take up documenting in electronic medical records than physically writing. So I now appreciate that in itself is something we need to be able to manage appropriately, because those are the same persons that 10, 15 years down the line are now going to,
Be in charge.
exactly.
Do you have speech to text technology?
Not currently in our
Yes.
EMR
That is very
facility in
helpful.
the
If you have speech to
hospital,
text
but
technology, it is really super helpful in expediting your case noting.
okay.
Yeah. Mhm.
Thank you.
Thank you.
Thank you so much, Mr.
All right.
Musazi. I see another hand raised. Oshia
Yes.
Allen Watson. We're really not in the question and answer, but we'll just give you the opportunity
Well, it's a
to
good,
ask your question.
thank you. It's a good time because I have to jump off afterwards. So if they have questions for me, this would be a good time.
I also
Okay.
saw another
Good afternoon.
question.
O'Shea Allen
Can you
Watson was
explain
about,
what the second victim syndrome?
yes. So it is re-traumatization. Like you can, each time you see case and you see more and more of the case, then you might start to internalize symptoms and feel like you're a lot a part of that situation. So it is a lot of re-traumatization from exposure. I see a thing about a coach.
Um, hello.
Yes.
I'm not sure how far into the question you would have heard. I fell off. I'm not sure what
Yes. I
happened.
didn't hear your question.
So I was asking, is there a correlation between fulfillment outside of work and fulfillment at work? And if so, is that correlation direct or indirect?
Well, it's
Meaning,
really, if you have fulfillment outside of work, it helps to take the edge off. So it's a direct kind of a correlation that people, if you people who have fulfilling lives outside of work would be less likely to suffer because they have more balance. So having balance is a big part of being well. So they can really, maybe endure the situation a little better. It provides them with some kind more resilience.
Okay, so what would you say to somebody who may have a fulfilling life outside of work, but the more fulfilling their life is outside of work, the more resentment they feel towards work?
They might need to find another job. They might need to find, something else, to do. Because if the workplace, I have a colleague who would say she came in the mornings and she sat in her car and prayed, before going into the office, and then she had to look for something else because that workplace was now harmful for her. If you feel that way about your work, or if people feel in that way about their work in spite of having a good life outside of work, then it may be time to find a space that is more conducive to your values. It could rub against what you know to be right or is important to you in the workplace.
Okay, thank you.
Thank you.
Dr. Libo, I see a hand raised.
Yes, good afternoon, Professor. Thank you
Hi.
very much. Thank you very much for that presentation. I'd put a question. How do we dismantle a culture of, well, I did it and we survived, so should you? And usually it is the seniors who hold that opinion, and it's very hard for the juniors to even complain or even mention it to anybody because they're afraid of reprisals and they're afraid of being seen as weak. So how do we dismantle that culture?
Yes, this is the idea that we have to it's a whole rite of passage. You have to walk over fire in order to get to where you should be. And if I could do it, then so could you. And so it's a very slow, very, very slow process. Um, it's a very slow process, and it really involves committed leadership. It has to be work. It is a top-down kind of a situation because it's going to be it's challenging. So people would have to be working consistently with leadership who would be open to change. However, the people who are emerging as those older leaders who believe in walking over fire, depart. And if the people who are coming up into leadership did not like the fire walking, then as people phase out, then you may have a new generation of people who have a different worldview. So that is what we hope for.
Thank you very much.
It is
Thank you.
hard. It's very hard.
Thank you so much for
Okay.
those questions. And also thank you so much, Prof. Always with us. You are the
Okay.
one who helps us keep the mental health in great shape. Every presentation, you're here to really keep us floating, and we are really so thankful for your presentation. Now, at this time, we would have been hearing from our sponsor, which is Sagicor. Of course, we cannot do these sessions on our own, and we depend on persons who are there in the private sector to help us. But our sponsor from Sagicor, Mr. Clean Walshy, he is under the weather and he's really missing such a presentation that would have taken him over the weather, but he's really not in a shape to be out with us. He's one of the most searched after financial advisor from Sagicor. 15 years, including the top of the table and court of the table qualifier. He is responsible for Sagicor Cayman in US, in investment, life, and critical illness. And at this time, we really just want to wish Mr. Cleon Walshy a speedy recovery and hoping that the next time around, he gets to come back as our sponsor and also to be here physically to share with us. So we continue with our presentations, and I know we would have loved to have Professor's presentation as the last, but of course we have to deal with everyone and whatever else is on their plate. So our final presentation, and I'm looking at 896 persons on. We went up to 909 earlier. At this time, we are going to be hearing from Dr. Donnelly Townsend, and she's going to be looking at vaginal discharge, the importance of accurate diagnosis and treatment. And Dr. Donnelly Townsend Wilson joined the Spanish Town Hospital as a medical intern in 2010. She later pursued and completed the Doctor of Medicine degree in obstetrics and gynecology in 2017. She currently works at the Spanish Town Hospital in the capacity of senior resident in the Department of Obstetrics and Gynecology. Ladies and gentlemen, help me to welcome Dr. Donnelly Townsend Wilson.
Good afternoon, everyone. Thank you so much. I hope on the heels of Professor Fletcher that everyone can remain engaged in this presentation. Today, we'll be talking about vaginal discharge, an approach to diagnosis and management. We will look briefly at some statistics, define and classify what a vaginal discharge is, the common causes, the clinical features, some of the diagnostic tests that are available to us, as well as management. So a vaginal discharge is one of the most common reasons that women access healthcare worldwide. While frequently benign and physiological, changes in discharge can be an indicator of an infection, an hormonal imbalance, or underlying pathology. So despite the prevalence, the topic is oftentimes under-discussed. It's mismanaged due to stigma, diagnostic challenges, assumptions with, in clinical practice, as well as just, stigma that creates a wall between patients and their physician. So the aim of this presentation really is to reinforce the importance of a structured approach to evaluation, highlight key diagnostic differentials, and to review evidence-based treatment that support better patient care. So the management of abnormal vaginal discharges is difficult, especially in a developing country as ours, because oftentimes laboratory facilities are not readily available or sometimes not affordable. So there is a paucity of data. However, in Jamaica, we currently practice a syndrome-based approach according to the WHO guideline. So I looked at a short study that looked at the Comprehensive Health Center over a 6-month period. It was pretty much a sentinel site, and they were evaluating the syndromic management of cervicitis and vaginal discharges at that clinic in Jamaica. What came out of that study was that, okay, Trichomonas vaginalis, chlamydia, Neisseria, you see the prevalence there. But less than 50% of these STIs were detected by a laboratory test, a diagnostic laboratory test. And more telling was that patients who came back for follow-up, less than 50% of them were actually cured. So what is this saying to us? That patients who come to our clinics who are being syndromically managed, they're coming back with reinfection, either incorrect or inadequate treatment, failure to comply to treatment instructions, possibly lack of patient education, or treatment failure. So these are all causes for concern why we would need to ensure that we are keen in identifying the discharge and managing it appropriately. So what is a vaginal discharge? It is a mixture of liquids, cells, and bacteria that lubricate and protect the vagina. They are constantly produced by the vagina and cervix, and it exits the body through the vaginal opening. The composition or quality of this discharge varies between individuals and can vary through the menstrual cycle, through the stages of sexual and reproductive development as well. So vaginal discharges are broken down as physiological or pathological. Further to that, pathological discharges can be non-infective or infective. So the composition of the vaginal flora or ecosystem is not static, but it changes over time in response to endogenous influences. So with the rising estrogen levels, there is abundant secretory activity of the endocervical glands and the vaginal epithelium, which create this glycogen-rich environment. The glycogen is then metabolized by the hydrogen peroxide producing lactobacilli into lactic acid. And this acidic environment protects against the growth of pathogenic organisms. So the normal vaginal flora remains heterogeneous, but it is predominantly lactobacilli. So oftentimes you can find other agents such as Gardnerella vaginalis, group B strep, etc. And this also speaks to the very dynamic and complex microbial colonization that takes place in the vagina that causes a normal commensal in the vagina to participate in a disease process as well. So this is based on the level or stage at which you are also in your maturity. So this is just a brief characteristic chart of what your vaginal discharge or normal vaginal discharge would look like. So it's odorless, it's colorless or white, and it is non-homogeneous. It can be thick or thin depending on where you are in the cycle, and bearable in amounts. So the common causes of pathological discharges now we will go into, now knowing what normal looks like. So we will expound on some of these infectious causes as well as non-infectious causes. So as was mentioned before, the syndromic approach is based on the understanding that in a low resource setting, you may not have all of the diagnostic facilities available to you right on hand. And so sometimes just by clinical examination, you should be able to have a clear idea as to what you may be dealing with. So there are infective agents that affect the ectocervix and vagina, leading to a vaginitis and resulting in a discharge. And the differentials are there, including bacterial vaginosis, candida, and trichomoniasis. And then you have other agents which can affect the endocervix, leading to a florid cervicitis and possibly a PID. So bacterial vaginosis is the commonest cause of an abnormal vaginal discharge in the reproductive age, and it is due to an overgrowth of facultative anaerobic organisms and the lack of the lactobacilli. This leads to an alkalization of the vagina, and risk factors include age, douching, and sexual activity. Now, even though it is associated with increased sexual activity, it is not considered a sexually transmitted condition. And so most patients may present as asymptomatic, but if they do present as symptomatic, may have an abnormal vaginal discharge with a vaginal odor. Trichomoniasis is a sexually transmitted condition, and it is caused by the infective agent, a protozoan parasite, Trichomonas vaginalis. Like bacterial vaginosis or BV, there are prevalence disparities favoring Black women. Most patients are asymptomatic, but if they do present with symptoms, they will come with that abnormal vaginal discharge, itching, burning, and sometimes intermenstrual bleeding or postcoital bleeding as well. The risk factors for this include multiple sex partners, unprotected sex, low socioeconomic status, as well as douching. So we're now at vulvovaginal candidiasis, which is the second commonest cause of a vaginal discharge. It is as a result or represents inflammation and infection of the Candida species. The most common causative organism being the Candida albicans, which accounts for up to 92% of cases. Patients also may be asymptomatic, but also can also present with severe vulvovaginal symptoms, including burning, intense itching, swelling to the vulva or vagina, as well as the abnormal discharge. And the risk factors for this condition include patients who are in immunosuppressed states, like diabetics, patients with HIV/AIDS, patients who have undergone chemotherapy, pregnancy, which is a very common occurrence, patients who have use of oral contraceptive pills, patients who have had long-term use of steroids, as well as broad-spectrum antibiotics. So we are now moving to the agents now that cause the cervicitis, and most frequently, chlamydia and gonorrhea are implicated, also often leading to a PID complication, but we're not going to get into PID per se. But chlamydia is caused by the Chlamydia trachomatis bacteria, and it affects columnar epithelial cells. This particularly places adolescent females, the younger age group, at particular risk because of the presence of that squamous columnar junction on the ectocervix, on the ectocervix. So it's not necessarily in the endocervix, but more on the outside. So these patients are particularly at risk. Also, gonorrhea, also the second most commonly reported STI, caused by the gram-negative Diplococcus, the Neisseria gonorrhea, and its primary sites of infection are the mucosal membranes of the cervix, the urethra, the rectum, pharynx, and conjunctiva. Risk factors for these conditions: multiple sex partners, unprotected sex, poor socioeconomic status, exchange of sex for drugs and money, and also previous history of a STI. We're going to briefly just look at some non-infectious causes. So we have atrophic vaginitis, which is a part of the genitourinary syndrome of menopause. And it is usually due to a low estrogen production at this stage of your life. The lining of your vagina gets dry, it gets thin, and therefore easier to be damaged. Patients usually present with vaginal spotting. They may have soreness in the vagina, burning, and also pain with sexual intercourse. An additional condition, which is almost close but not exactly the same, is the desquamative inflammatory vaginitis, also seen in our perimenopausal age group patients. It is a chronic condition characterized by inflammation and an odorless, purulent discharge. So it's also frequently associated with burning and dyspareunia, and the patient might have some itching as well. The underlying cause of this particular condition remains unknown. Of course, we have to consider other non-benign causes of a vaginal discharge. Whereas it is very unusual to be a primary symptom, it is important to consider these differentials, especially if the history or the presentation of the patient suggests same. So you have cervical cancer that can present as a watery bloody discharge, foul smelling as well, especially in advanced stages, endometrial cancer, vaginal cancer that can also at points present with abnormal vaginal bleeding, a watery or bloody discharge as well. And then you have non-infectious vaginitis, which is, signs and symptoms suggestive of vulvovaginal inflammation, but in the absence of a pathogen. So oftentimes, foreign bodies, mechanical objects, chemical irritants like soaps, and allergic reactions can be implicated as well. And briefly, we look at the vaginal discharge in the pediatric population. The most common cause of vulvovaginal pruritus and vaginal discharge in children are external irritants or infections. And a common contributing factor, especially in the young girls, young babies, 2 to 6 years old, is poor hygiene, wiping from back to front after bowel movements or not washing hands after bowel movements. And you find also that um, chemicals like bubble baths and soap sometimes can cause irritant vaginitis as well, with a lot of itching as well as foreign bodies, which may be non-specific, but cause abnormal, unusual discharge, which sometimes can be bloody as well. Less common, but very important to consider, is a vaginal discharge in a child who may be suspected for sexual abuse. So approaching these children, we have to be very thorough and also keen to ensure that we are ruling out any foul play. So we will now look at clinical symptoms. So this is the part where I hope that we will all kind of just focus into, because this is what we're going to be doing at our point of care, places of work, etc. So a woman comes with a complaint of a vaginal discharge. So what's the approach? You want a complete medical history. You're going to examine her, as well as you have in-office tests that may be available. But let's say, you don't have those available right now. So this is what we're talking about. In the history, you're going to be asking the patient about the symptoms. What is the color of the discharge, the consistency? Is there any odor associated, itching or burning? You're going to ask the patient about their sexual history, whether or not they're active, if they've had a prior history of a sexually transmitted infection before, or prior diagnosis of a vaginal infection. What are the number of partners, lifetime partners, or if there are any new partners? Are they using any current medication, self-medicating with over-the-counter meds or prescription medication? If there's any vaginal hygiene practice that might predispose the patient to having a discharge, like shaving or douching, and other medical underlying conditions like diabetes, HIV, inflammatory bowel disease, etc., that might put the patient at risk as well. Where are they in relation to the menstrual cycle? Because oftentimes some patients may come thinking that they are having a pathologic discharge when it might actually just be physiologic. So it is also important to garner information about the partner. Is your partner experiencing any of these symptoms? If there are any penile discharge or irritation, that could also be helpful and contribute to the likelihood of your assessment. So when you examine the patient, you're going to be doing a speculum examination that is warranted, along with a bimanual pelvic examination. And this, you're going to be able to assess the actual discharge and the contours and size of the uterus, but also if there's any pain associated. So if we have a patient who has a healthy looking cervix, but you're seeing that discharge, florid discharge it may be, or not, and with a negative bimanual pelvic exam, you're going to be considering the differentials for a vaginitis. If the patient has a discharge coming out of the cervix is looking very unhealthy, cervical erosions are present, you may even have contact bleeding, then the patient might be having a cervicitis, and this is on the background of a negative bimanual pelvic examination. Because if the patient is having cervical motion tenderness or uterine tenderness at all, then you're now going to be starting to consider a diagnosis of PID. So on examination, when you look, if you're seeing a white or creamy or clear discharge adherent to the vaginal walls and fornix, the patient didn't have any itching or odor, and you happen to have a litmus paper and it is normal, or acidic, I should say, then this is what your physiologic discharge, the characteristics of same would look like. So let us talk about how the discharges for pathologic discharges look. So you have on examination a thin, watery, milky white discharge or gray discharge as sometimes discharge, that is sometimes described, coating the vaginal walls and with a fishy odor. The patient doesn't necessarily have any itching or so, and the litmus test is on the alkaline side, then you're probably dealing with a bacterial vaginosis. If you have a patient with a thick, curdy white discharge, often described as cottage cheese, I've heard wet bread, on the background of intense itching, splash dysuria, that is, when you pass urine, it burns a lot, or having significant pain, but with a normal acidic pH of the vagina, then you're dealing with vaginal candidiasis. And if you're having a yellowish, greenish, frothy discharge associated with a significantly foul odor, intense itching, patient has pain with urination, the patient might even, on examination, you might notice these small powder burn, or I don't know if powder burn is the term, but petechial hemorrhages on the cervix, then that is actually diagnostic for trichomoniasis vaginalis. And we call those petechial hemorrhage or erythema of the cervix, of the vagina, as the strawberry cervix. So with regards to our cervicitis presentation, which commonly chlamydia and gonorrhea are implicated, you may have, I'm not sure if it's reflecting as yellow, but it's usually a yellow or mucopurulent vaginal discharge with a mild odor. Patient might actually be misdiagnosed prior as a urinary tract infection because they tend to have very significant urinary symptoms. Also on the background of the intermenstrual bleeding that we were speaking about, rectal bleeding or discharge, then you might be dealing with a chlamydia gonorrhea picture. Of course, again, if you have a positive bimanual examination, then this patient now has to be considered for PID or pelvic inflammatory disease. The other infective causes or non-infective causes that on examination, how the patient would look. So for atrophic vaginitis, you may pass the speculum and find that the vagina is pretty dry, it's shrunken, it's you might find that you might have a little bit of occhiatic and redness to the vaginal walls. Might or might not, you may not, most times you may not have a white discharge associated, then you're probably dealing with atrophic vaginitis. Very common in the menopausal and perimenopausal age group as well. Discriminative inflammatory vaginitis will be seen as a purulent, odorless discharge in the vagina with significant irritation, also erythema and petechial hemorrhages to the vaginal wall. And the patient, for these two conditions, if you were to do a litmus test, it would be alkaline as well. So let's say we had all our office-based tools available to us to even further confirm what this diagnosis or what the diagnosis of that abnormal vaginal discharge could be. We have not only the litmus test that I was referring to before, but you also have your potassium hydroxide test, which basically is a whiff test. We call it a whiff test, where you would basically sniff the mixture of vaginal secretions and potassium hydroxide and see whether or not you have that strong amine odor or strong fishy musty odor. Additionally, you can do your wet mount or microscopy, where if you have a microscope available to you, then you would be putting the discharge or on both potassium hydroxide as well as 0.9 normal saline. You look at it on the low and high power under the microscope, and you look and see what you see. Sometimes use these as additional measures that can help. Obviously, not many people have that. FDA has commercial kits now that are readily available that can easily give you the similar information. But let us look at what the differences look like. So on the microscopy, you will see for bacterial vaginosis, you will have, for the whiff test, you will have a positive whiff test. And on microscopy, you're going to see your clue cells, of which you need at least 20% or more of same, no white blood cells, and decreased or absent lactobacilli. This is pathognomonic for bacterial vaginosis. And you will find out why as well later on. So you've seen how this microscopic picture looks. And what you're seeing is some branching or budding pseudohyphae with occasional white blood cells seen on the background of lactobacilli. And with a negative whiff test, that is likely candidiasis. And then you may have this look under the microscope where you're having these motile flagellated organisms with white blood cell present, decreased lactobacilli. We're dealing with trichomoniasis. And the whiff tests for these patients tend to be variable. So it might be negative as well as it may be positive. The microscopic description for patients with atrophic vaginitis as well as desquamated inflammatory vaginitis are similar, and patients tend to have an abundant amount of white blood cells with parabasal cells, which are immature squamous cells, with decreased or absent lactobacilli. So you would also see that with a microscopic test. So the diagnostic test for bacterial vaginosis is the Amsel's criteria, and you heard when I mentioned to you why it is pathognomonic, because it's a clinical criteria that is used to diagnose bacterial vaginosis. It is sensitive, highly sensitive, and highly specific as well. So it consists of the homogeneous thin white discharge, gray discharge that you may see, as well as the clue cells on microscopy, the pH or litmus test that is alkaline, and your positive whiff test. Of these four, you need to meet at least 3 of the criteria to make a diagnosis of bacterial vaginosis. So even if you didn't have a microscope, you should be able to still even make the diagnosis of a BV if it were to be present. There are also other diagnostic measures that can be used, like the Nugent score, or we call it the bacterial vaginosis score, which is pretty much a ratio of how much gram-positive rods, lactobacilli versus the gram-negative rods and gram-negative bacilli that may be present. So it's a nominal factor that is placed. So pretty much depending on the amount of these varied organisms that you're seeing, a score is applied. And if you have a score, an overall score of 0 to 3, then your diagnosis is normal flora. If the score is 4 to 6, then you have intermediate flora, for which you can possibly use your AMSEL's criteria to confirm, okay, is this a true bacterial vaginosis, yes or no? And you can also, and then if you have a score of 7 to 10, then bacterial vaginosis is diagnosed. So this is how it would look when you send a patient with a high vaginal swab and you get back the report. A gram stain is done, and then you will see the BV score right here. I'm not sure. Okay, the BV score. Are you seeing the pointer? Yes. So the BV score right here, and so these are pretty much where the scores are coming in. How much gram variable rods are you seeing? How many gram negative bacilli are you seeing? How many large gram positive bacilli are you seeing, which is a normal bacterial which is the normal lactobacilli that you'll be noting. And for this patient, that's all she had, lactobacilli. So at the end of the day, her score is 2, and so she had a normal flora. For trichomoniasis, the diagnostic test of choice is your nucleic acid amplification test, which is the preferred way of testing. It is significantly sensitive and specific in determining the presence of trichomoniasis. You also have antigen detection testing, which is also available. It's used mostly as a point of care option or rapid test or rapid kit, where you can get a result back in 10 minutes and can be able to now expedite the management or treatment of the patient. Note well that patients may come, you've done a pap smear, and you found that the patient had Trichomonas vaginalis, an incidental finding on a pap smear, either conventional or liquid-based. Please note that it is not considered a diagnostic test for trichomoniasis. And so in these patients, it is preferred to retest with a sensitive diagnostic test and to treat if the infection is confirmed. So with for vulvovaginal candidiasis, the patient, the diagnostic criteria really is examination of a wet mount with the potassium hydroxide preparation, and it should really be performed for all women with symptoms of vulvovaginitis or vulvovaginal candidiasis. So for those patients with wet mounts, with a negative wet mount, but exhibiting signs of vulvovaginal candidiasis, then you can move on to doing your culture to see whether or not the candida species is present. Obviously, if you don't have that available to you, then you may go ahead and treat empirically for same. For chlamydia, the nucleic acid amplification test also is the gold standard for treatment, and it is diagnosed with using the use of a vaginal or cervical swab, or first void urine for women, and for men, a first void urine or urethral swab. There are also point of care or rapid kits also available. They're coming now more in vogue that can help to expedite the management of patients who may potentially be infected. So, but usually it is the nucleic acid amplification test or some of the FDA-approved antigen detection kits. For gonorrhea, the culture is the most common diagnostic test that is used for this condition. The swab is usually taken from the endocervix, transported in the Stewart's medium, and placed on the Thiel-Martin medium. Also, you can utilize nucleic acid amplification tests or PCR tests as well. That can also be helpful. Significant gram stain of a urethral discharge or secretion that is demonstrating these pathognomonic polymorphonuclear leukocytes with intracellular gram-negative diplococci can be considered diagnostic for infection of gonorrhea. So the management of these conditions. So bacterial vaginosis is treated with metronidazole, 500 milligrams orally, twice per day for 7 days. Or you can use intravaginal preparations with metronidazole gel or clindamycin gel or cream. Also, patients are asked during treatment and up to 3 days after treatment not to engage in any sexual intercourse. Why? Because oftentimes, especially like with the clindamycin ovules, they can actually, even if you use a condom, they can weaken the latex or the rubber product and therefore cause unplanned, unwanted pregnancies. So we're always especially also with the success of treatment. You ask your patient, try not to have any sexual intercourse, but if you must, use a condom. But also, even with that, depending on the treatment of choice, especially clindamycin ovules, they can actually weaken the rubber product. All women with bacterial vaginosis should be tested for HIV and other STIs because the potential for co-infection is very high. So even though it is not considered a sexually transmitted infection, it has been implicated in PID. And this is where the debate arises as to whether or not partners should be treated opportunistically as well for bacterial vaginosis. We say the treatment of the partner is not necessary, but especially in patients with recurrent bacterial vaginosis, that is 3 or more separately documented episodes in a year, then these patients should be highly considered for partner treatment. In these patients, you might consider giving a long-term course of metronidazole gel for over 3 to 4 months. The alternative regimen for bacterial vaginosis, apart from the metronidazole, clindamycin 300 milligrams orally, twice per day for 7 days, or you can use the intravaginal ovule preparations as well as tinidazole. Significantly, in pregnancy, I would like to mention that it is important to treat symptomatic pregnant patient because this bacterial vaginosis is associated with adverse pregnancy outcomes, including premature rupture of membranes, preterm birth, chorioamnionitis, postpartum endometritis. However, be careful with what you're using. The tinidazole is not safe in pregnancy. For trichomoniasis, the treatment of choice is your metronidazole, 500 milligrams, 2 times per day for 7 days. For women, recommended regimen for men, you can give metronidazole 2 grams orally as a single dose, or you can consider giving your tinidazole 2 grams as a single dose for both males and females. Tinidazole was shown to be, though it's a little bit more expensive than the metronidazole, it was shown to have higher effectivity in treating trichomoniasis. The gel, the reason why we don't use local therapy alone for women is that the gel didn't reach the therapeutic levels in the urethra or paravaginal glands, and so it was less efficacious. So oral metronidazole therapy is recommended, or you can use a start dose of the tinidazole for the women. Concurrent treatment of all sex partners is vital. It is a sexually transmitted infection, and this is primarily to prevent reinfection. Current partners should be referred for presumptive therapy, or if the patients or the patient is recommended for opportunistic or expedited partner treatment if your local authorities permit same. For pregnancy as well, trichomoniasis vaginalis must be promptly treated as it is also associated with adverse pregnancy outcomes, including small for gestational age babies. So for your vulvovaginal candidiasis, you can see the over-the-counter preparations that are available for treatment, which include your intravaginal cream therapy for over 3 days or 7 to 14 days with either cotrimazole or miconazole. You can also utilize miconazole vaginal suppositories over a 3 or 7 day period, depending on the dose that you're using, as well as you can use prescription drugs like your fluconazole oral single tablets as well for use. Uncomplicated vulvovaginal candidiasis is not usually associated with sexual intercourse. However, a minority of males or male sex partners have balanitis characterized by erythema of the glans penis with irritation and pruritus. So in these cases, you might consider giving the partner treatment as well. Recurrent vulvovaginitis, especially caused by the non-albicans species of Candida, account for 10 to 20% of your recurrent vulvovaginal candidiasis. And so sometimes your conventional therapies, as mentioned before, may not be as effective. And so you may have to either lengthen the duration of treatment or add your oral fluconazole weekly for 6 months in order to overcome this infection. Vulvovaginal candidiasis is very common in pregnancy, but please note that you can only use local therapies. Only topical therapies can be used, applied for 7 days as recommended, because you cannot consider the use of oral fluconazole as it is associated not only with spontaneous miscarriages, but also with congenital anomalies, and so it should be avoided. The recommended treatment for chlamydia is your doxycycline 100 milligrams twice per day for 7 days, or your alternative is your azithromycin 1 gram orally as a single dose, or your levofloxacin 500 milligrams orally over 7 days. Treating patients with chlamydia prevents not only adverse reproductive health outcomes, but it's imperative to treat so that you can minimize the risk of long-term complications. It is important to treat the partner and so that you can minimize the risk of transmission. Therefore, also in pregnancy, a special consideration is when treating pregnant women, the use of doxycycline is contraindicated, and so your azithromycin regimen is what is utilized for these patients as a single dose, or alternatively, you can use your amoxicillin 500 milligrams PO 3 times a day for 7 days. As mentioned, prompt treatment of chlamydia prevents the uncomplicated sequelae of this infection, which includes PID, tubal occlusion, infertility, Reiter syndrome, which is arthritis as a result of the chlamydia, Fitzhugh-Curtis syndrome, perihepatitis, or hepatitis, include the risk of ectopic pregnancies, significantly so, as well as in pregnancy, preterm births, postpartum infection, and ophthalmia neonatorium. The treatment for gonorrhea recommended is your ceftriaxone 500 milligrams IM as a single dose for patients who are less than 150 kg, and you may give your 1 gram ceftriaxone for patients who are over 150 kg. If you're having patients who may be having, or you may not be able to rule out a chlamydial co-infection, you're also asked to give co-treatment with doxycycline. The alternative treatment for gonorrhea is if you don't have the ceftriaxone or allergic reactions to cephalosporins, then you can use gentamicin 240 milligrams IM as a single dose plus your azithromycin 2 grams orally in a single dose. In patients who may present with a clear cervicitis, but the etiology is unknown, as mentioned before, you're going to treat these patients as chlamydia, syndromically, basically, with the chlamydia covering for chlamydia and gonorrhea, as well as your trichomoniasis and BV. So the ceftriaxone targets your gonorrhea, the doxycycline 100 milligrams targets your chlamydia, and that's given over 14 days, and the metronidazole targets your bacterial vaginosis and your trichomoniasis. So just to complete that, in the management of patients with the non-infectious causes like your desquamative inflammatory vaginitis or atrophic vaginitis, the treatments for these conditions are for your DIV, you will give local vaginal clindamycin or vaginal corticosteroids. There's also the consideration for cryotherapy, especially if the patient is experiencing the PV spotting as a result of a cervical ectropion or so. And for your atrophic vaginitis, these patients are primarily treated with estrogen therapy, either topical creams, tablets, or estrogen releasing rings. These therapies are utilized to help to restore the vaginal wall, reverse the vaginal atrophy, improve the growth and maturation of the cells, and enhance blood flow. Additionally, lubricants are also utilized in these patients, especially if their primary symptom really is the dyspareunia. Obviously, caution needs to be utilized when using estrogen in this age group. So, in conclusion, vaginal discharges is a common presentation with a whole range of potential causes from physiological to pathological, but an accurate diagnosis guided through history, physical examination, and appropriate lab tests will be helpful in making the accurate diagnosis. And timely intervention not only alleviates symptoms, but also plays a critical role in protecting the reproductive health and preventing the spread of infections. Thank you so much. These are my references. If we have time for questions, I'm open, but if not, that's my email. You could ask your questions there as well. Thank you.
Thank you so much, Dr. Townsend.
All right. So again, take some of the questions. We have a number of questions in the chat. So going to take our post and look at some of the questions having. You should be seeing the poll now. We have 4 questions on vaginal discharge. And we'll give you about 2 minutes for everyone to answer. Of course, in the meantime, if you have any other questions, you can continue to put them in the chat. few responses coming in. We've just reached about 100 responses. We'll take another minute and then we'll reveal the answer. Person's not seeing the poll. If you're using your mobile phone, you might have to click the three buttons at the side to open up. I don't know about a few persons might not see this. Take a break at this. All right, so we have some 222 responses, and we'll just ask Dr. Townsend to take us through these, and then we'll mention some of the earlier questions that we saw.
All right, hi, good day. All right, so let's start with the first one. So the AMSL's criteria, Nugent score of 4 and a positive whiff test are all diagnostic of bacterial vaginosis. Recall that the AMSL's criteria, yes, 3 out of 4, is diagnostic. A Nugent score, however, of 7 to 10 is what diagnoses bacterial vaginosis. So a score of 4 would be an intermediate diagnosis. And so on the background of a positive whiff test, then would have to be false for this answer, right? Because of the Nugent score of 4, it would be 7 to 10. The appearance of a strawberry cervix is a sign of chlamydial infection. Recall that trichomoniasis, this is actually the pathognomonic finding for that condition. So those cervical petechial hemorrhages that you will see that are described as a strawberry cervix, pathognomonic for trichomoniasis. So the answer is false. What is the most common cause of a vaginal discharge in a child under 10 years? Remember, we said that it is likely due to an external irritant or allergic reactions to soaps, etc. We also mentioned poor hygiene, but for this question, it's kind of a gray zone, but I would still go, if we had the option of an external irritant, I would go with that. And so I would go with chemical allergic reactions to soap, etc., followed by poor hygiene. And in your 23-year-old student, university student, presenting with a complaint of dysuria as well as a foul-smelling vaginal discharge. She's sexually active, 2 partners, inconsistent condom use. Examination reveals a frothy yellow discharge with an erythematous cervix. She has no tenderness on bimanual palpation. Which of the following would confirm the diagnosis? So we have positive whiff test. We have a vaginal pH of 3.5. We have the presence of flu cells on microscopy, positive nucleic amplification test. This patient is experiencing GC. So a positive nucleic amplification test is your answer.
Thank you. Townsend. So,
But the frothy, sorry. Hello?
yes, you can go ahead.
The frothy discharge. Let's go back. The frothy yellow discharge is actually your pathognomonic sign. So the patient would have a presence of clue cells on microscopy to suggest. No, the test would be a trichomoniasis. Patient has trichomoniasis, and the answer is a positive nucleic amplification test. She doesn't have GC, she has trichomoniasis, and she has the pathognomonic test of choice is your positive nucleic amplification test.
Dr. Townsend. So let's see. The first question we had from much earlier in the presentation, well, two questions about BB. I'll twin them together. One person asked, given that BB is being now considered as an STI, is there benefit in treating both patient and partner in the interim while they're working on that classification? And a related question, if a woman has recurrent bacterial vaginosis, should the partner be treated as well?
Okay, so these questions were actually addressed specifically in the presentation. So currently the CDC guidelines do not recommend the automatic treatment of the partner for bacterial vaginosis. Opportunistic treatment or expedited partner treatment is not recommended. However, you're correct when you say that the patient who has recurrent bacterial vaginosis, that is more than 3 episodes for the year, those patients who are high risk also for sexually transmitted infections, those patients would benefit from having partner treatment. And so it is now being considered to actually start to routinely treat these patients and their partners for bacterial vaginosis. And that is primarily to prevent reinfection. So I hope that answers the two questions. So patients with recurrent bacterial vaginosis also would fit the criteria for partner treatment. But currently, the CDC guidelines do not recommend its automatic treatment for partners.
All right. Thank you, Doc. One person had said that Caramed is using urine sampling to diagnose most of these STIs and asked if you could comment on the sensitivity of this.
All right. So
yeah.
we have found that the endocervical swab is has a better yield in terms of diagnostic relevance of the test. However, a first void urine can also be used, but you have to bear in mind that these patients may actually have a false negative. So we do recommend, mostly for the men, they will do their first void urine, but for women, if possible, and you can get an endocervical swab, that is much, much better. But sometimes you may not have the bacteria in the vagina. So if with the urine washing out some of what is there, you may not catch the the agent that might be in the cervix or further up. That is your chlamydia, gonorrhea. So it is better to treat or to investigate these patients with the use of an endocervical swab.
Thank you.
But especially if it's like
this other person had asked if you can have baby wipes causing vaginitis and a foul discharge. About the vaginal discharge.
Right.
Can baby wipes cause that?
Right, because sometimes there are we call possible to cause a contact dermatitis as well as a vulvovaginitis and resultant discharge. It is possible. So it is more prudent to utilize agents that don't really have too much of the cosmetic components within them. So if you can just use regular water or plain wipes, that's fine. Should be better.
Yeah. All right. Someone had asked if we can safely prescribe Flagyl in the first trimester of pregnancy.
Okay. So currently, the CDC guidelines state that there is no adverse outcome associated with the use of Flagyl in any of the trimesters, and so it should not prevent you from utilizing this medication in the treatment of your bacterial vaginosis, in the treatment of your trichomoniasis cases, as early as the patient presents in symptomatically. Breastfeeding, just come over gel is not going to cause any adverse side effects. So yes, you can treat in all trimesters with your metronidazole.
This next question asks, how often can vaginal inserts be repeated in pregnancy? And a follow-up question to that, can you alternate boric acid inserts if there is persistence of candidiasis due to hormonal changes?
Can you repeat the first question, please?
So the first question was, how often can vaginal inserts be repeated in pregnancy? And can you alternate boric acid context of repeated infection in pregnancy? There's a risk.
So once a patient remains symptomatic of their vulvovaginal candidiasis, it requires treatment. But sometimes if you're remember, the vulvovaginal candida can also be, or candida, I should say, can also be a normal commensal. But if you're having a discharge, meaning symptoms, itching, pruritus, once it is there, you can proceed with treatment for as long as you need, because sometimes there is a bit of resistance also. So that might even have to prompt you to look into culturing and to see whether or not there are any non-albicon sources of candida that might be associated with this recurrent vulvovaginal candida. But even then, the patient in these cases also would require extended treatment with your topical clotrimazole or miconazole. In addition, boric acid can be used to treat yeast and fungal infections. I am not fully sold on its use, but there have been recent studies to suggest its efficacy in the use of patients with vulvovaginal. But I've also seen the contrary, where patients have even worsened symptoms with its use. So it's debatable. It's still out for me, still out for consideration.
Is out on that. All right, we only had two more questions in the chat, and perhaps they might even be related. So one person had asked if there's any utility in using amoxiclav for the treatment of STIs. And another person had asked related to that, that the 2022 guidelines say gonorrhea should be treated with Rocephin, a 250 milligram IM dose, and they're asking if that has changed based on what you had presented earlier.
Right. So let me just take that last one, and you may have to repeat that the first one that you just said. But yes, so based on the CDC guidelines, the use of 500 milligrams IM is what is used for patients who are less than 150 kilograms, and for those greater than 150 kilograms, you use the 1 gram of ceftriaxone. The question before that?
I want to ask you if there's any rule for using amoxiclav. I think this was in general. That was asked when you had the service sites of unknown etiology.
Right.
But they just
No,
asked
there
for
was
STH.
no. No, there was no recommendation unless it's unless the patient has allergic reaction to ceftriaxone or it's not available as a alternative regimen. But primarily you want to go with your doxycycline for 14 days, your metronidazole, and your ceftriaxone.
Thank you so much for this, Dr. Townsend. I will.
Thank you so much, Dr. White. And we have now come to almost the end of today's present. The rest call back the others. But before we go into the after party, I am not competent enough to give thanks to all the persons who would have prepared to, who would, I'm not competent enough to give thanks and to do the wrap up for this afternoon session. So at this time, will you please help me welcome Sister Keisha Riley Harrow, who is tasked this afternoon with the wrapping up of the session on vigilance in action, safety in practice. Please give her a warm welcome.
Thank you very much, Director Robinson. And we know what she said is not true. She is more than competent. But having done such a wonderful job as our moderator, our powers that be felt it prudent to allow her to have this moment to just sit back and relax. So I want to say a special thank you to the organizers of this session before I go into our wrapping up. It was a wonderful day. In vigilance in advertisements and best practices through improved knowledge and skills in prioritizing patient safety and well-being. We'll be able to enhance understanding of common healthcare challenges and best practices. We started off this afternoon session with Dr. Trevor Bygrave discussing the mitigating transfusion errors, understanding the strategies to minimize transfusion errors and ensure patient safety. And those that were here would have appreciated his extensive presentation. And I really hope that he's still on. We want to say a very big thank you. We appreciated your efforts with the audit and the findings of the audit. And we know that it's a work in progress where we will continue to see how we can work together to have those resources in place, the checklist, further audits, to see how best we can make sure that we have safety in practice. We moved on to Dr. Heather Brown-Henry, who presented viral rashes versus non-viral rashes, a diagnostic challenge. Dr. Brown-Henry gave us a very detailed description of the features that separated viral versus non-viral rashes, macular erythematosus, popular rashes, and I found her presentation to be extremely fruitful in that she discussed the different types of rashes. She brought about what were the diagnostic investigations and the treatment. And I really think that she did a stellar job in bringing all of that information across in such a way down to the very layman could have understood what was that separated even the drug exanthems, those, what she called them, those common drugs that were at fault for creating these rashes. And we know that we can call upon her at any time for our very difficult cases. And so we say a big thank you, Dr. Heather Brown Henry. We moved on to have our next topic being done by our visiting resident Professor Wilma Fletcher Anthony, who took us through burnout, depression, or both. I know many of us, though we didn't put it in the chat initially, would be experiencing some of these issues. And she had us reflecting and thinking, are we having the symptoms? What are we now, having recognized the symptoms, going to do about it? And I saw many of the participants engaged with her in the very discussions that brought up some of these suggestions. And I hope that management will review the recordings, come together and see how best they can work together with us to ensure that our staff are being vigilant in not only the work that we are doing in the workplace, but also the importance of self-care. Self-care among health workers is extremely important and needs to be addressed. And we really thank Professor Wilma Fletcher Anthony for bringing that to the fore this afternoon. Though we miss our Sagicor representative, Mr. Cleon Walshy, who should have been here with us due to ill health, we do hope that he is recovering well and that he will be with us at our next presentation. But we had a very stimulating session with Professor Wilma Fletcher Anthony during that period, and it gave many persons an opportunity to ask questions and really bring out the issue at hand. And finally, Dr. Donnelly Townsend Wilson, thank you so very much for your presentation on vaginal discharge, the importance of accurate diagnosis and treatment. Dr. Townsend really brought along her knowledge and expertise in the field, really going in depth into the different types of vaginal diseases and the types of diagnostic tests that should be done to confirm accurate diagnosis to ensure accurate treatment for these issues. And we need to remember that a thorough history, physical examination, and appropriate laboratory testing are extremely essential for the treatment of these vaginal discharges and diseases. I really thank you all, my participants. Thank you to the in-service team. Thank you to the secretarial team. Thank you to Dr. Wright James STH Webinar team for ensuring that this afternoon's webinar is the success that it is. We had up to 914 participants, and we had a fruitful session, and we really appreciate you for joining with us this afternoon. Give yourselves a round of applause. You all did very well. I now hand over back to my moderator for her final words. And so, ladies and gentlemen, there you have it. We have come to the end of our first webinar for 2025. And I'm sure you were not disappointed. You would have had the wrapping up done by Sister Keisha Riley Harrow, but I just want to say thanks for those persons who would have started us off with the presence of the Lord, inviting the presence of the Lord in our midst. I want to say thank you to the technical team. If you realize we're getting better at it
every day. So we have our technical team today, and the team gets smaller and the presentation gets more seamless. So it just shows that we have improved in our competence. Thank you so much, Dr. Sharian Mackenzie. Thanks to Dr. Matthew White for taking us through the question and answer segment. For the team who prepared the room, I'm so sorry that we have to go online for you, so you miss out on being in here. And I would have had 1,314 persons registered, because while you would have had someone on, it may be that more than one persons are actually in the room listening and partaking in the presentation. It was my pleasure to have been your host this afternoon. I want to thank all the presenters, the sponsors, all Sister Marika Powell and Sister Riley Harrow, who assisted in preparing the room, and also to our adopted teacher, who is an all-rounder we could not have had today outside of Peter being with outside of our SMO, whose brainchild, because without her, we would have had no seminar. I just want to say thank you also to our CEO, who finally got the opportunity to come by and join us. We want to say thank you for her presence here in the room. And of course, I didn't say one thing. If you know my SMO, you would know the reason she's able to make these presentations is that she does not sleep at night. I want to thank all the participants from all over, from the US, from the Antigua, from BVI, Dominica, Cayman, Bermuda, St. Lucia, all the members of the Caribbean organization. It's so good to see you online. And I realize that a lot of persons were in on that presentation by Professor Whitman. But I just want it, that presentation grabbed a lot of us. So I want you to know that if you see me talking to myself, just move along. Because really, I'm self-employed and we're just having a staff meeting. It was my pleasure chairing this session this afternoon. Thank you, and we look forward to our second webinar for the year, which will be on Wednesday, May 28th, 2025. And I'm sure you do not want to miss out on any of that. Remember to fill out the Google Doc form so that you can have your e-certificate sent to you. And persons were asking if the sessions would be made available, because we do have our own YouTube channel. So you can just log on and you will get all the presentations. Thank you so much for logging on. Thank you so much for staying the course. And we'll see you May 28th. Thank you so much. Bye. Music.